Tonight is meant to serve as a healthy dialogue between a well-respected organization, the American Cancer Society, and the concerned citizens of Polk County. As Breast Cancer Awareness Month wraps up, it would be very easy to close our minds to the sense of urgency needed in addressing these recommendations. So we do somewhat apologize for the swift nature in which we tried to get word out to those who wanted to bring voice to their concerns, and to do so pronto. I'm Connie Bamberg. I'm a 3-year survivor. I was diagnosed at 45, and I'm completely convinced that had I been more diligent about my mammograms and gotten them sooner than that, my circumstances may have turned out quite differently than they had. It's my pleasure to now introduce our guest speaker. I had the opportunity to sit with Megan only a few short days ago, and I gravitated to her personality and her kindness as she respectfully talked to me about how the ACS came to their conclusions and why they have made these changes, though I still don't agree. Even after our quality time together, I'd like to ask and remind you to please be respectful and understanding that Megan is a messenger, and we need her to not just hear maybe our outrage, but rather our voice of reason. So please, when the floor is open for time for you to speak, recognize that she is here to answer those questions that she can, and to carry back with her to the Florida Division Office those questions she cannot. She will, however, elevate awareness of Polk County's concerns within the walls of her own organization. Megan Wessel is the Vice President of Health Systems at the American Cancer Society's Florida Division. She leads a team of 35 staff to work with state-based hospitals and primary care health systems. Hear this. It's in order to further the Society's mission to save lives from cancer. Okay. She's been an employee since 2001 and has served the division in a variety of roles, overseeing prevention, early detection, and quality of life initiatives. She has worked in the healthcare industry for 20 years. Megan earned her bachelor's degree in psychology from the University of North Carolina and a master's degree in public health from the University of South Florida. I invite you, Megan, to the podium to show us how you're going to save more lives with these changes. Thank you.
Well, good evening. I am not one for podiums, so I'm going to move around. I think I have too much energy, or nervous energy, maybe that's it. But thank you for that introduction, and first and foremost, thank you for coming, because I know that there are a lot of things that you could be doing, and probably you need to be doing tonight, so thank you for making the time to be here. She did describe Connie described a little bit of my background, but I wanted to share with you my perspective about how I got to this place with the organization. That bio is a little old. I've actually been in the, I wish that it was only 20 years, but it's over 25 years in public health. And I started my career in maternal and child health, and then I worked to increase access to primary care in rural and underserved areas, many that are similar to areas of Polk County. And then I worked in heart disease, asthma, and diabetes, trying to help patients throughout this state. And then cancer, and I've been with the cancer field for about, as you said, 15 years. But it's more than a job for me. It's very personal. I have kind of a staggering number of people that I've lost in my life to cancer, from friends, family, staff, coworkers, but nothing has affected me more profoundly than the loss of my mother, my grandmother, and my aunt to ovarian cancer. They were all premature deaths. They were all very, very, very difficult. And I'm at high risk for breast cancer, as is my sister, because of the high level of ovarian cancer in our family. So this is personal. It's personal to me about cancer overall, and it's personal to me about breast cancer. So when I talk to you today, I'm wearing a couple different hats, and I hope you'll take that into consideration. So you might be wondering, why in the world did you do this, the American Cancer Society? Why did you change these guidelines? Well, we, as you may know, we were the first organization to recommend mammography as a screening. We also have been one of the leaders, if not the leader, in trying to encourage the use of mammography in women 40 plus, and also to make sure that everyone had access to it. And we have done this for decades. So why now? Have we changed our goals as an organization? Absolutely not. We want to change the course of this disease. We want to reduce the burden of cancer and breast cancer in this country and throughout the world. So that hasn't changed. And in order to do that, we have to reduce mortality. We have to do it with breast cancer because it is so common. And do we think that reducing screening is going to get us there? No, we don't believe that. We believe increasing screening in the right way at the right time is going to save more lives, and the data shows us that and the science shows us that. So I wanted you to know how we came about this, why we decided to do it. The other reason that we did it is because, as you know, there have been for years now huge debates in this country about mammography. There are a lot of organizations, well, some organizations and people who question whether we should do it at all. And then how often we should do it. So there's organizations that say we should start at 50, like the World Health Organization, like the United States Preventive Services Task Force. They recommend starting at 50, going every other year, and ending at 74. There's organizations that say start at 40. So women, and those of you that are in the healthcare industry or the public health field, you know this is very confusing. And a lot of women shut it off because they don't know what to do because there's so many mixed messages out there. So a few years ago, we decided as an organization that we had an obligation to this country because we are, in the cancer field, where we are one of the most trusted sources of information. We said we had to get this right. We have to do something to help provide clarity to the breast cancer screening debate. So that's why we did it. And I know you have a lot of questions, and I want to help you with those. So let's get right into it and talk about what kind of answers I can help you with. So I want to give you a little bit of background. This part might be a little bit boring, but I think it provides some context why we decided to do this. So our last guidelines were done in 2003, and that was a long time ago. Mammography was different then. The studies that we used to develop those guidelines were older, and frankly, it's overdue. We should have probably waited this long. We probably waited too long to revise them. But in 2011, the Institute of Medicine created standards on how to establish clinical guidelines. And they were designed to make sure that guidelines are established without bias, they are scientifically rigorous, and they're high quality. So we decided to utilize the IOM guideline, the standards for developing guidelines. And the first step was to make sure that we understood all the research that had been done around breast cancer screening in this country and throughout the world. So we had to turn over every rock and stone to make sure we knew all the studies that were done. We knew the strengths of those studies, the limitations of those studies. Research studies that are published, there's always pluses and minuses to them. So we decided to contract with Duke University, and you'll see it's the Duke University Evidence Synthesis Group. And we actually spent a lot of money to ask them to do this for us because we wanted to make sure we didn't miss anything. We knew we had to get this right. We knew we were going to be under enormous scrutiny, and we should be. So we did this, we got the information, and then based on the IOM guidelines, we developed a guideline development group, the American Cancer Society Guideline Development Group. And on this group, there were no ACS staff that were voting members. It was all external key stakeholders, clinicians, scientists, we had patient advocates on there, and that was the core group that did this. We also pulled in external experts when needed, but we had no ACS staff that was voting. We really wanted to make sure this was as scientifically valid as possible. I want you to know there were no representatives from the healthcare insurance industry on this group, zero. Also, when we were gathering the evidence, the review that Duke University did, as well as when we developed the guidelines, we did not factor in cost. We did not factor in anything with the healthcare industry, reimbursement by insurers. We did not focus on that aspect of it. This was solely done to focus on women and their health and their outcomes. There's been some confusion out there, so I just want to make sure that that is clear. We don't even have that level of analysis available. We focused purely on women's health. So we also focus on average risk women. We have high-risk guidelines, and we're actually reviewing them in 2016. So in 2016, you will have an updated high-risk guidelines, screening guidelines for women. But right now, you are considered average risk if you have not had a personal history of breast cancer, if you do not have a confirmed or even suspected genetic mutation. Now, for example, I don't have a confirmed genetic mutation, but because of the age that all my family members and the severity of their diseases, they suspect that I have a genetic mutation. So I am considered high risk for breast cancer because of that. So there's a lot of, it can get a little tricky, but so suspected or confirmed, and you can talk to your clinician about that. And then a history of radiation to the chest, 30 or younger, or under 30 years of age. So if there was any reason you had that, if you had a childhood cancer or something like that, you would be considered high risk. So we're just looking at average risk. So these are our guidelines. I'm going to get right into them, and then we're going to talk about each area, and then we're going to talk about some screening data and some other things. I don't have the longest presentation. I think there's only 14 or 15 slides because I really wanted to give you an opportunity to talk and ask me questions. So let me start here. So starting at age 40, for average risk women, I'm talking about all women starting at 40, we are recommending talk to their doctors about their breast health and getting screened. Hopefully, they've already talked to them years earlier about their family history. And what they really should do is look at when you're a teenager, teenage girls should try to find their family history for on their mother's side and their father's side. Unfortunately, I have ovarian cancer on both, which is even higher, more challenging for me. And there are probably some of you in the room that have breast cancer on both sides. So we want to make sure that you know that family history young. But we're putting that aside for now. 40. All women should talk to 100% of women, which they're not now, not even close, are talking to their doctors when they turn 40 about getting screened. And if 100% of those women want to get screened, they should. And we are actively, and have for years, and will continue to do so, advocate that women have access to those mammograms and are able to get them at a low or reduced cost. And I can tell you that you might have remembered a few years ago when the Affordable Care Act went into play, and they said that they were going to use the United States Preventive Services Task Force guidelines to cover reimbursement. That was what was required to offer, so that would have been 50. And what the American Cancer Society said at that time was no, it should start at 40. You might remember Debbie Wasserman-Schultz. She's a legislator that lives in Broward, and she actually advocated for it to start at 40. And that legislation passed, but it's getting ready to expire. I don't know, I can't remember. I think it was active for 15 years, I think it was. But anyways, she is now using our guidelines to advocate for that law to stay in place and to not go to the USPSTF, which is the task force guidelines, but to use our guidelines. So because we are saying every woman should have access at lower reduced costs, and through the Affordable Care Act, there's no cost for those screenings. So, at 45, and the reason we're saying 40 to 44 is that the numbers are lower. It's not rare. Breast cancer is not rare in that age group. It's lower. And I know that those of you in the room will acknowledge it's not rare. We're not saying that. It's lower. Also, mammography, breasts are denser when we're younger, and there's more false positives. There's a lot of controversy about overdiagnosis. Those of you in the clinical world probably saw there were publications all summer long about the overdiagnosis of breast cancer. So there are a lot of issues there. And all we want to do is have women talk to their doctors about those potential complications, right? It takes about, so women who have to be called back if there's some kind of something suspicious or they're concerned about something, 2,000 women, roughly 2,000 women have to be called back for additional follow-up to diagnose one breast cancer. So it's not 2,000 women to be screened, it's 2,000 women to have that follow-up. So there's a lot of false positives, there's a lot of controversy about overdiagnosis. So all we want is for women to be empowered and make an informed decision during those earlier years in your 40s when the data isn't as strong. The data shows exactly kind of the benefit to mammography. We are saying that there is a benefit. We are supporting mammography of women in their early 40s. We know it saves lives. What we're saying is, at those early stages in your 40s, talk to your doctor about the risks and benefits. And if 100% of women choose to do so, we want to make sure they have access to high quality, low cost, if not free, mammography. But then at 45, the data changes. And at 45, it is pretty solid. And we want, no matter what your personal preferences are and your guidance with your doctor, 45, everyone should be having annual mammograms. And that really lasts for the next 10 years. 10 years, 55 it's really after menopause, but by 55, most women have gone through menopause. So there was some discussion, do we say after menopause, but we decided just to have a cutoff of 55 because most women are done. And after you go through menopause, your breasts are less dense, the cancers tend to be a little bit slower growing, excuse me. And so mammograms, when you look at them for identifying late-stage disease and for reducing mortality, after 55, whether you get screened once a year or every other year, the results are almost completely equal, right? So this is the data. The data shows because, again, your breasts aren't as dense, the cancers tend to be slower growing, mammography is better. Every decade, mammography gets a little bit more effective. So in your 50s, it's a little better than your 40s. In your 60s, it's a little better than your 50s. In your 70s, a little better than your 60s. It's just because of the way our breasts change at different stages in our lives. So at 55, as an organization for providing population-based guidelines, again, that's what these are. These aren't guidelines for you and your family to make a decision about your health care with your provider. That's what you do with your provider, with your family, and you make those decisions. These are population-based guidelines. And what we're saying at 55 is the data shows that it doesn't make that much of a difference. It doesn't make any difference between annual or 12 months or 24 months. But if you want to do it 12 months and once a year, you absolutely should do that. And you should have access to it at low or no cost. And we support that. Now, there are a couple different organizations that say every other year starting at 50, and you might wonder, well, why is it so different? Well, a lot of organizations have looked at the decades, like 40 to 50, 50 to 60, 60 to 70. What we did is we broke it down. We looked at 40 to 44, 45 to 50, and so forth. Excuse me, let me just take a little sip of water. And what we found was that 45 to 50 and 50 to 55 were pretty similar as far as the benefits of mammography. So we really wanted those years to be called out. We think it's so critical during those years. And then remember, your risk of breast cancer increases as you get older, pretty substantially. 40s, 50s, 60s, 70s goes up. So mammography is just as important, if not more important, the older you get, because your risk is higher. But the reason we have the interval option, 1 year or 2 years, is purely because of the data and what it shows. Then, what we say is you do that either annually or every other year, as long as you are healthy. That's what we're saying. Now, how do you define that? Some of our materials we've had saying if you have at least a 10-year life expectancy. I don't think any of us know if we have 10 years. But that is a guide to help you make that decision. But if you feel healthy, in consultation with your doctor, and you want to continue screening, you continue. My mother-in-law's in her mid-80s, and there's no indication she won't live to 100, and she's in great shape. I have an aunt who's in the same age, who has a lot of health issues. And she recently had an annual mammogram, and they found cancer, and she had a double mastectomy, and she's having chemo. And it has destroyed her quality of life, destroyed it. And she didn't have 10 years left, and she knew that. And if she had been, instead of just going into the annual, she said to me, if I had had an opportunity to talk to my doctor, I don't think I would have gotten a mammogram. I would have just focused on my kids and my grandkids and enjoying what time I had. That's a personal decision that she needs to have that opportunity to make in consultation with her family and her doctor. So, USPSTF recommends stopping at 74. The reason that they do that is because a lot of women are dying of other things at this past 75. But we feel, as an organization, is that women, you have no idea how long you'll live. People have all different levels of health. You should continue doing it as long as you feel healthy in consultation with your family and your doctor. So this is really the way our guidelines are. It's really, and I mentioned this to Connie last week, it's kind of like a roadmap for you to follow. In 2003, their guidelines, we didn't even consider informed decision making, or we didn't consider kind of a personalized approach to guidelines, or really in medicine very much at all. But now we're really looking at personalized medicine for treatment. We're looking at we want to sure women have an opportunity to make an informed decision. So this is a roadmap for you to follow at different stages in your life, when your preferences and your values are different, when your bodies are different. But no matter what, starting at 40, throughout your entire life, we want you to be empowered, take control, have access to health care, and access to mammographies annually if that's what's right for you. And I will have to say that when we roll this out, and I'll give you a little bit of information about us rolling it out that I forgot to say earlier. We established these guidelines in the most scientifically valid, unbiased way we possibly could, because we knew that we were going to have, we were under a microscope, and we were going to be critiqued, and we should be. We absolutely should be. So we thought, okay, they were done early this year in the spring, and we said, should we publish them in one of our medical journals? The American Cancer Society publishes 3 journals. One of them is where we usually publish our guidelines, in the January issue of, I believe it's CA. Or should we try to get it published in a very prestigious medical journal? Because when you have it published in that journal, they critique it before they publish it. Okay? They tear it apart before it ever gets out to the world. And we decided we wanted that additional critique. We wanted that additional, tear it apart. So we went to the Journal of the American Medical Association, known as JAMA, and that is one of the most prestigious and well-respected medical journals in the world. And we asked them if they would be interested in publishing it. They reviewed it, they critiqued it, they thought it was excellent. They went from the editors back to the authors, back and forth for several months, like, can you clarify this? Can you add this? Just like any medical journal publication does. That's just standard practice. It took several months to go back and forth to really make sure that we had turned over every rock and stone, and we had provided clarification for every area that needed it. And then JAMA was going to publish it, and we didn't have any say of when they would publish it. And if we tried to influence that, in my opinion, that would have been unethical, because it's their publication and they should publish it when they feel it's appropriate. We shouldn't base it on, Breast Cancer Awareness Month or our events or anything like that. So I know Polk County had a Strides the Saturday before. That was probably not great timing, and I can tell you nationwide we wouldn't have picked October either, but we wanted to be objective and unbiased and not influence the process. So JAMA, this is customary in publication, they embargoed it. So they said nothing can be shared until 11 o'clock on October 20th. And it was a Tuesday. Now, it is customary for them to send that out to the major media outlets like CNN, ABC, CBS. That's just the standard. So they did that, right? But it was still embargoed. And then at 11:02 on that Tuesday, all those media outlets pushed a button, because now we're instantaneous knowledge exchange in this world with the internet, and they published the guidelines, right? And so that put our key stakeholders, which are you, all of you, our volunteers, our donors, our clinicians, our partners, in the dark, right? Our staff in the dark. They didn't know either. So, we learned a lot of lessons from that process. And we got a lot of things wrong rolling that out. We were so focused on making sure that we weren't going to make a mistake with the data and the science. I think we should have focused more on how we communicated it. Part of it was the media just running for certain, taglines that they do. And part of it is how we provided it to the media. I mean, we have to take some ownership of that too. So we have a lot of lessons learned. And our national leadership, I can tell you, recognizes that. A lot of key messages were lost. A lot of key messages which were misinterpreted. It just was really a shame because we upset a lot of people and we hurt a lot of people that were very devoted and committed to us. And including some of our most critical stakeholders, like Connie here. So, I want to just reinforce a couple things. So the guidelines, they provide women guidance and control over their health decisions. And more, we're going to have to do that with healthcare, especially as we go into the age of personalized medicine. And there isn't, in many cases, it's not going to be a one-size-fits-all scenario for us. So we're going to have to be empowered and knowledgeable. We believe there should be no financial or other barriers into ensuring that women can make these decisions. It's absolutely critical that they don't have barriers. They need access to high-quality mammography. They need to be able to get there if they have transportation issues. They need to be able to have it free or low cost. And then all women should have the opportunity to start at age 40. And I think that I've talked about that. So, women under 40. We're frustrated just as you are about what to do with women under 40. We wish there was more. Mammography has never been and probably will never be the best tool for women under 40 because the cancers are much more rare, they're harder to pick up, the breasts are dense. It's just not the screening for it unless you are at high risk. But I'm talking about average risk women under 40. What we need to do is find a blood test. We need to learn more about genetic testing. So, and we are investing in that. Millions and millions and millions of dollars to invest in that because we need to have something for women under 40 in their 20s and 30s. But I talked about this a little bit. What we need to do and what we try very hard to do and all of you should do with your friends and family is women in their teens and no later than 20 should find out their family history. Father's side, mother's side. And they need to talk to their doctors. If they have one or more direct relatives, they should talk to their doctors about genetic counseling and genetic screening. They may or may not need it, but they have to have that conversation. And if their doctor doesn't want to have that conversation, they should try to get a second opinion. So what can we do? I mentioned that we can find new ways to measure risk to see really what level of risk are you. Right now we have high risk and average risk. Maybe there's other levels in there. Maybe there's something we don't know. We're still studying that. So, and we have to find more effective treatment for our younger women that sometimes get more aggressive cancers. So there's a lot that we can do. And we also have to ensure we have access to care for everyone. So women, young women can get access to care, have regular primary care contacts, and so it'll increase the likelihood that these high-risk cancers, high-risk women will be identified, and also women, if they see or notice any changes in their breast, they need to talk to their doctors immediately. And that goes for every woman starting at 40. We have to always report any changes, even if it's 2 months after you have a mammogram. One of my aunts died. She was screened, had a clean mammogram. 2.5 months later, she was diagnosed with stage 4 breast cancer, and she died a year and a half later. So mammograms are not the perfect. We recognize they're not perfect. They are the best that we have, and we know they save lives. They detect about 85% of breast cancers. So there's about 15% that they just do not detect. So we have to focus on improving that technology. Now, some of you might ask questions about 3D mammography. All the data and the research that we looked at, there wasn't really enough on 3D mammography. We know it's growing and it's becoming more available, but it's not particularly prevalent now. When it becomes that way, we will take that in consideration for revising our guidelines again, because it could end up being the norm, and it could really, it could shake this up. But right now, the norm is 2D mammography. So what about clinical breast exams? So clinical breast exams, I don't know if you realize this, but we are not recommending them anymore. And the reason is because they are not an effective form of screening. They are not. Mammography is an effective form of screening. And that's what our guidelines did. Remember the beginning I said, what do we need to do this for? The country was in debate about whether they were even good. We're saying they are. The clinical breast exams are not. Now, if your doctor wants to do it and you want your doctor to do it, that's perfectly fine. We are not recommending against doing it. What we're recommending is saying it's not a breast cancer screening. So if you do it, don't consider yourself screened for breast cancer. And there are some countries in the world, third world countries and other ones that don't have access to mammography like we do. And in those cases, there is still a benefit to clinical breast exams because it's better than nothing, right? But in our country, we really do have pretty good access to mammography. And in those pockets around the country where we might not have great access, we need to first improve the access to mammography. That's why we don't recommend, as a screening tool, clinical breast exams. So screening, what's going on? We're very concerned about what's available, and what guidelines are, and what recommendations are, but it's kind of shocking how many people aren't getting screened, even with the guidelines that we have. So, you can't see this very well, but the bottom line is that health insurance companies that are accredited have to report quality measures related to diabetes, heart disease, cancer. In cancer, they report on pap smears and colon cancer screening and breast cancer screening. They report, so you can compare one health plan to another, their screening rates for women 50 plus every other year. That's the measure that health insurance companies use to demonstrate their quality of preventive care regarding breast cancer. 50 plus every other year. So the screening rates, whether you're on commercial, Medicare, or Medicaid, through a health insurance company, because there's a lot of different product lines, so there's slight variation, range from about 59% to 74%. So between 30 and 40 people, 30 and 40% of women that have insurance are not even getting screened every other year. It's a big number. So then if we look at a screening rate for annual mammograms, and this is the Behavioral Risk Factor Surveillance Survey. This is, you might hear people call it BRCS. It's a Center for Disease Control survey that's done throughout the country to look at health indicators, whether we smoke, whether we exercise, if we're overweight, if we're getting screenings, those kinds of things. This is for women starting at 40, going to 74, with annual mammograms. So in Florida, it's about 57% of women. In Polk County, it's about 50. So that means in the state of Florida, roughly 50% of women are not even getting annual mammograms, right? It's a lot of opportunity, a lot of opportunity. One of the reasons we adjusted our guidelines is because we knew this data, right? Why aren't women getting mammograms? Well, it's confusing. It's confusing. I'm scared. I don't know whether to start at 40 or 50. I don't know whether to go every other year or every year, right? So I'm not going to do it. I don't have a family history. A lot of women aren't getting screened. A lot of women aren't getting any screening, right? Or they do it once every 5 years or once every 8 years or just whenever they feel like it. That was one of the reasons we had to revise our guidelines. We needed to provide clarity to women. We needed it to be scientifically rigorous. We needed to be data-driven, so people couldn't eat it apart, because if we didn't do it really well, then they would say it wasn't valid. People aren't agreeing with it. They're saying they don't like it, but you can't challenge the science on it. You can challenge whether you agree or not. What we wanted to do is say, we have a problem with women, too many women dying from breast cancer. Too many women are not getting screened. What are we going to do about it? We're going to help them, number one, be informed, empowered women to make educated decisions about their health. We're going to give them the best science there is and the best guideline that we can give them. The best guideline that we can give them is 100% of women 40, talk to your doctor. Start screening if it's right for you. If you choose not to, it's non-negotiable at 45. Non-negotiable. Do it. You've got to do it. And you've got to do it every year for 10 years. Really, really critical. And then at that 55, you still have to do it. You have to do it. We're not recommending you stop doing it. But at least do it every other year, at a minimum. Our guidelines are what to do at a minimum, right? Might be for you the ideal is starting at 50 the rest of your life every year. But we need to get these rates up. We need to get them up fast. And we need to get them up by telling women the minimum to do, right? Like, I don't know about you, but you hear the guidelines, at least exercise 30 minutes a day, 5 days a week. And when I get off my exercise patterns, I think, God, at least if I do 30 minutes a day, 5 days a week, like at least if I do that, maybe it's something. So what we're telling women, at least talk to your doctor at 40, get an annual mammogram until you're 45 if that's right for you. Don't put it off at 45. At 45, do it for the next 10 years every year. And then after that, as long as you're healthy, do it at least every other year. At least. This is minimum guidelines. So, regardless of the guideline change, I just wanted to reinforce with all of you that we will be there for cancer patients, breast cancer patients, all patients. Regardless if you want to support us in this recommendation or not. 1 out of 2 breast cancer patients reaches out to the American Cancer Society, and we provide support for them. We do that in a lot of ways. A lot of ways they don't even know about, through our research and our advocacy efforts. But we also have our National Cancer Information Center. We have nurse oncologists available. We have cancer information specialists. We have an insurance assistance program. We have a partnership with an organization that provides legal advice, counseling support, helps with insurance companies if they're not covering something that they feel needs to be covered. They help find out if they have other financial problems because of the cancer diagnosis. There's a lot that we do, and we're available for them. And we want to make sure that they start a conversation with their physician. Remember, 50%, almost, well, 50% in Polk County, but almost more throughout Florida, are probably not having that conversation. Or if they are, they're dismissing it and they're not taking action. So we want to have the conversation. We want to have the best, absolute best information that they need to be empowered to make those decisions. We want them to make informed decisions about their health. This support that we've provided, 81% of the women that we give this to find that it helps them make better decisions and be more confident in the decisions that they're making. So You know, some of you might think this is the biggest challenge that we've ever faced. Right? It's all over the news, Good Morning America, you know, it's all over. They're mad, some of you are mad, some of you are critical. That's okay. That's okay, because you know what it's doing? People are talking about it. People are talking about it. On our side, we learned lessons. We're trying to correct those mistakes that we made in our communication of this. We're trying to improve how we talk about it, but people are talking about it, which is really important. And now I believe that with your support, and passion is overflowing in this room, I know from the stories that Connie told me, and even the fact that you're here when you might rather be home doing something or out and about. I actually think that this might create the biggest opportunity to increase screening, because it's providing clarity. And it's going to take time. It's not going to happen overnight. Some of you are not going to be happy when you leave tonight. You might not be happy 3 months from now. But hopefully some of you, this provided some clarity. And as the weeks, months, years go on, maybe you'll feel different, maybe you won't. But we're going to still push on and increase these screening rates, because if we increase them, more lives are going to be saved. And there's a lot of opportunity. So that's my 2 cents. And I would love to take questions from you. Yes.
My name is Sam, and I was diagnosed at 41. I had no family history whatsoever. And here's my concern. I'm sorry. I'm Sam, and I was diagnosed at 41. I just completed chemo a month ago. Today? It's been about a month. I have chemo brain. If any of you have gone through chemo. So my concern is this. One, when I see the commercials on TV right now for American Cancer Society, which seem to be more, they're fundraising. Why are they not providing more clarity for the guidelines that are out there? One. And number two, I don't understand, mine was not found through mammography, but I'm a huge proponent of it. But I don't understand the benefit of telling a doctor that they do not need to examine your patient. If it's free and it doesn't cause any harm, why would we veer away from that? Because if my doctor hadn't looked at me and said, you know what, let's just check you 4 months after my clear mammogram, then I wouldn't know I have breast cancer or had breast cancer.
Sure.
So those are my 2 concerns. Why are they not correcting it with, you know, I understand the fundraising and what you need, but why are they not correcting it with commercials or information out there? And 2, why are they taking away doctors doing that?
Sure. Okay. So as far as the clinical breast exams, I'll start with that. Clinical breast exams do not lead to identifying advanced cancers at any better than not doing them. Doing them or not doing doesn't. Will some cancers be found by a clinician? They may be. But it's not a screening. It's not an effective screening tool. It's just not.
I understand that,
And
but I don't understand why you would stop it if it still has saved
What
lives.
we're saying in the guidelines, we never once said, doctor, stop doing it. What we say, it's not recommended as a screening option, because it's not. It's not an effective screening option, right? So we can't recommend it as an organization to say, this is an option for screening. So what we would say is that it's not a screening option. If doctors want to do it, if patient wants it, you can continue, but it's not an effective screening option. So we
Don't you
can.
think it's a mixed message? I mean, if you're saying in third world countries where they don't have access to it, it's effective and viable, but
It's
here-
not effective and viable. What it is it's the only option that is available. So years ago, when we first started mammography, there was a benefit to it because mammography wasn't as strong. Now, it's not an effective, when you look at the studies, it's not an effective screening tool. So we're not saying don't do it. What we're saying is, it's not gonna, you're not screened, you do it, right? It's not your screening. These are guidelines for screening. And it's not a screening, it's not beneficial as a screening guideline. Doctors want to do it, they can do it. Patients want to do it, that's fine. What we want to focus on is the screening that works. Which is mammography.
Noreen, do you want to expand
A little
on
bit
this
better.
particular question?
Well, this is really kind of a quandary that you get in when you go back and you look at, let me just say, I'm Norrie McGowan, and I actually work in the Center for Research at Watson Clinic, and I'm actually the administrative director there. And when you look back retrospectively and gather all of the data, you're looking retrospectively at a trial and trying to gather thoughts in a kind of aggregate way. You know, you're trying to get it all together and try to bring back the evidence that you can render from each trial and make an assumption. So remember, all of that, there's every individual trial, and it's got inclusion and it's got exclusion for people who get enrolled in those trials, and especially when you're dealing with prevention. So many times the quandary of the breast exam is that it's subjective. It's not an objective test like an X-ray is. So that presents for many of the reviewers, when they're looking at it, that they're going to say, you know, there's only a small percentage of people that possibly had a palpable exam by breast exam versus the mammography looks really clear. I can see that. I can have evidence for that. So evidence-based trials that go through the JAMA and the journal have to have that kind of information so that they get published, because it's just an assumption or a subjective piece of it. So there are a portion of the patients who present like you, who have a palpable mass, and they feel it. They feel it. They're the first ones to find it because they're doing their monthly exam. And then they show up in the doctor's office and they say, I feel something here, and the doctor feels it, and it goes on from that process on. But the reality is, it is a smaller number than the reality, and that's, I think it's the population study that I think you're trying to get at, and it's unfortunate the way it's been dispersed. I think you said that. It was communicated really poorly. It's a population study. It's kind of like when you look at mortality and you say, in Florida, this many people are going to die by this age, and you don't look at what were the reasons and the causes. So it's very different, a population study, than an application study. A study that actually says to the community, you should do this as a partner in clinical care. For us, it's very hard. We see only cancer patients. So a majority of the people that walk through my door have already been diagnosed. So it's very, very hard for us to see and wrap our arms around reducing screening in any way. So I think the other thing I wanted to say is some of the trials that you're looking at are still, like you said, years old.
Yeah.
So I don't really know exactly the breakdown. I'm sure you have that at your fingertips.
Yeah.
I think that would be helpful to get to the clinicians right now. Because I think the committee that reviewed it has it. They've got to have had it. So they have to understand which trials they looked at. And then if we could wrap our arms around that, maybe we could understand better. I think you shared most of the things, Megan, that are concerning. And I think from a perspective of looking at it from the clinician side, I'm just reluctant to try to apply it. And then one more thing, and I'll get off my part. The colon prevention thing that's going on this year is raising our awareness to start increasing our prevention of colon cancer. We are just being told by the American Cancer Society that 80% of they want to raise the number to 80%. And then they're jumping on reducing prevention timelines for, so that's very hard.
But it's not.
It feels mixed messaging.
It feels mismatched.
Yeah, it's not a mixed message though, and I'm sorry it feels that way. I just wanted to make a note to you that we also used observational studies.
Yes.
And the USPSTF only does the clinical trials. We felt like some of the observational studies were strong enough that we could incorporate it. So I can also give you the whole review. They published the review in JAMA as well.
Thank you.
So the message around colon cancer, it's very, very clear about screening for colon cancer. And not only can colon cancer screening prevent, because it can remove a polyp before it starts, it can also find them early when they're most treatable. So colon cancer is much cleaner than this because colonoscopies can find it, remove the polyp, potentially prevent the cancer. Well, mammograms don't prevent cancer, unfortunately. Also, there's a lot of overdiagnosis. There's complications with overdiagnosis. The debate is still out there. We're not really sure, but there's a lot of talk about that. That kind of complicates it. There's just it's more complicated than colon cancer. But what we're saying, we're not saying reduce mammograms. What we're saying is
Be selective.
be selective, do it when it's most effective, and do it. Because if we got our numbers up, if we increased our screening rates by 5%, 10%, the number of lives we save would be staggering. So to me, it's like, let's focus our energies on saving lives and finding cancers early and get these screening rates up. That's what's gonna do it. And educating women and
That's the piece. You just said,
Educating
educating
women.
women.
Yes.
This was not an education piece, but this is how it's being,
yes,
this is how it's being utilized right now.
Yes.
The community is thinking, I'm now educated.
yes, it wasn't an education piece. You're absolutely right. It was sort
That's
of-
the message that has to get out. You
Yeah.
have to re-educate
Yeah.
us all on why this happened.
Yes, and you're absolutely right, and that's what we are doing, and we are in the process of doing that. And this was the release of a very scientifically valid, population-based screening guideline. That's what it was.
Understood by very few.
I completely agree, or misunderstood by most. So,
Eva.
We're a little limited on court.
Hi, I'm Eva. I'm with We Care Project Think Pink. We are the only free mammogram program in Polk County for women who are low income and uninsured. So this is obviously very dear to my heart. A couple questions that I have for you. One, does ACS fund free mammogram programs? You can just say yes or no.
we do a wide variety of things.
Okay.
So what we do, and the only reason I said this, just so people can hear, I'll get right back. So in Florida in particular, I'm not sure if those of you that are familiar with the Mary Grogan Breast and Cervical Cancer Screening Program. So that provides free mammograms or low-cost mammograms for women 50 plus because they use the task force guidelines. And if they are diagnosed in that program, it also covers their treatment because that's a whole other issue. Is after someone's diagnosed, can they be treated? So that's one piece of it. So we were instrumental. We were in increasing that funding, maintaining that funding. Did a lot of advocacy around that. We also have funded hundreds, if not thousands, of what we call them change grants. They're I can't remember the acronym right now, but they're focused on partnering primarily with federally qualified health centers and lookalikes, which you're familiar with, that provide care to underserved communities. And there is a strong education piece with that, as well as screening. What we know is that if we change policy within a system, that has a longer term effect than paying for individual screenings. There are organizations like yours that do that. We do some of that as well. But what we try to do is change the policy. If you change the policy, the long-term effect can be potentially quadrupled.
And so is it the plan of ACS for these organizations, not the 15 plus, but for the partnership or the grants that you do, will you change your guidelines that now eligibility, these women it will be 45?
No.
Okay, and then one other question for you.
We support 40 coverage, low-cost access.
What will ACS do if insurance companies decide to change their guidelines and are no longer going to pay for it? You're prepared to lobby.
Yes. So I can tell you that right now, as I mentioned earlier that stipulation in the Affordable Care Act to go back to 50, to go to the task force guidelines, which are currently 50, they may change them. We're hoping they'll change them to be more consistent with ours because we think 50 is too late. They are using our guidelines right now. So that doesn't get kicked up to 50. So the legislators are using our guidelines, our new guidelines, which start at 40. That's what they're using to pass laws, right? And we're advocating for that, we're supporting that. So, and 100%, now we support the Mary Brogan program, even though it's at 50, because we couldn't change that guideline. But we are always absolutely advocating, we'll continue to do so. And fortunately, our guidelines are being used right now for that very purpose. Now, I'll tell you, remember the slide that had what we call HEDIS measures? So the health insurance, that's 50 now. So health insurance companies now are measured, their quality indicator for breast cancer is 50 plus every other year. We want them to change that, right? Because you do what you're measured on, right? Just like all of us. In our jobs, we do what you're measured on. So they're measured on 50 plus every other year. So why would they try to get every year or go younger? So we're hoping they'll change their HEDIS measures. And we're also hoping that, we will advocate always starting at 40. As long as, that's our guideline, which is 40 now. Yeah.
First, I want to thank you so much for all of that, and I'm not closing out the question period, but the American Cancer Society does put together some of the greatest education material relative to cancer. So I want to credit them for that, and in the hopes that we will continue to receive and get even better information in the hands of our community on some of these changes. My question to you is, why was changing the guidelines more important than addressing items that you mentioned in your slides that we've been hearing for many, many years? Access, addressing next steps. What has the ACS been doing as you talked about those items being of concern for so long? Why wasn't that the focus rather than the guideline change?
So a couple things. It's been simultaneous. So we have been advocating for access to care for women. We've been advocating for screening, for coverage. We had to do that. But remember, there was this big debate, do mammograms work, right? When should you do it? So here we are advocating for something, and they're telling us, well, your guidelines are old. Your guidelines are from 2003. So what we need to do simultaneously, we need to have the most valid data, science, recommendations, so we could stand by that and advocate for it. So these things happen simultaneously, but we couldn't go any longer. It would have been too long not addressing our guidelines. We look at our guidelines on a regular basis, and I hope that we won't wait another 12 years to do it, or 13 years.
All right, my friends, any other questions you'd like to address while we're here?
Are they gonna do something to launch a campaign to provide clarity? Because even sitting in this room, and I'm a smart cookie, it's so confusing. One minute we're talking about 45, but then you're saying you're a proponent of 40. It does not make any sense. There's no, what they were trying to provide is clarity. All they have done is muddy the water. And I understand the way it was pushed out was not the ideal situation, but how quickly is the American Cancer Society going to get in front of it? And one, how quickly are they going to get in front of any insurance companies that want to change for the women that do want to do it for them?
So, first of all, I think there's going to be complexity to this, right? Healthcare is complex. And this is a complex issue because mammography is not a perfect tool. Mammography only catches 85% of cancers, and it varies by woman, by age. We need a blood test. This is what we need. We need a really great blood test or genetic test or something. We need something better. This is what we have, right? We can't make it simple visually if the data and the science doesn't back it up, right? Because it's not fair to women to do that. We have to respect the science. So that being said, it's complex. I get it. This is the message now that we're going to, we didn't roll this out on October 20th. We did not do that. We messed up by not doing that. This is the message we're giving. This is about as clear as we can get, to be honest with you.
But when are they going to really push this out there?
We are doing that now. We're also developing decision aids for clinicians, decision aids for patients. We're doing nationwide, and we'll do it in Florida. And I want to make sure your clinicians have access to it. We're going to do some continuing medical education and other learning opportunities for clinicians, not only for primary care doctors. We actually started doing that already. We had one a week ago. But we're going to do it for oncologists and radiologists, and then also other healthcare professionals. So we are going to move as fast as we can. It probably won't be fast enough, but we're a big ship, and it's hard to get us to move too fast. But it's critical. You're making a valid, excellent point, and we're going to do it as fast as we can.
And Sam, know this, I'm not here representing Watson Clinic, but I work for Watson Clinic, and I can promise you that we are very, very committed to the educational component and helping work in collaboration with ACS so that this type of dialogue is happening in every pocket we can get into in our community, because it's this education that's going to make a difference, not only for the woman that needs to make the decision, right? But also for the future success of ACS to continue on and moving forward. So we want to have this dialogue, we want to have the conversation, and we'll have more.
And I just want to make one comparison to colon cancer, right? That screening is very complex, right? We have fecal occult blood tests, fecal immunochemical tests, so FOBT, FIT. We have colonoscopies, we have sigmoidoscopies, right? So it's complex. Why can't it just be colonoscopy every 10 years, starting 50? Well, what we've done, we've seen data that if people are offered options, this was fascinating to me that I didn't expect this. If people are offered colonoscopies, or they're offered blood stool tests, or they're offered one or the other, right? So just colonoscopy, just blood stool test, or either one, where are the highest screening rates? Right in the middle, options. That was the highest, that's where it was the highest because men and women were making educated decisions on what was best for them. To do the colonoscopy, there's risk associated with that. To do the FOBT, it's not quite, it can't prevent cancers because it can't